welcome. We want to thank you very much for being there with us, and also to all the people who connected again. Dr. Leroux is a gynecologist. Uh, she's also a urogynecologist. She has extensive experience both as a gynecologist and as a urogynecologist. She worked for 22 years at a university hospital in Montreal. The name of this hospital is Saint Justine. And then she moved on and co-founded her own clinic. The name of this clinic is Ansolia. The clinic is located in Montreal. And this clinic, of course, specializes in women's health. So this is for Dr. Leroux. And now I would like to pass it over to you, Dr. Leroux, so you can start your presentation. Thank you again.
Thank you, Olivia, and good evening to everybody. So I'm just going to share my screen. Olivia, just tell me if we're okay.
Yes, indeed. Yes.
We're good. Okay,
we all can see it.
Thank
you.
Starting here. Okay, so those are my disclosure of conflicts of interest. Like you said, Olivia, I'm a partner at Sansolia, and we own 2 lasers that I'm going to talk about in this presentation. So the objectives of the presentation is to recognize the signs and symptoms of genitourinary syndrome of menopause. We'll say GSM during the presentation because it will be easier. Then to describe the different treatments available for GSM, discuss indications for laser treatment in urogynecologic health, review recommendations in the literature, and understand therapeutic options to prevent recurrent urinary tract infection. So GSM is a term that was adopted in 2014 by the North American Menopause Society and the International Society for Study of Women's Sexual Health, because it's really a term that is more accurate and it's medically comprehensive when we compare it to just using the term vulvovaginal atrophy. It really includes all the symptoms associated with the urogenital atrophy, but also the lower urinary tract dysfunctions and sexual dysfunctions. So as for prevalence, you can see up to 22% of the premenopausal women will be suffering from GSM. It might look like it's not possible because your patient is still menstruating, but sometimes when she starts skipping, when the level of estrogen is starting to decrease, some patient will be really sensitive to the lower estrogen level, and they'll already start to have symptom of GSM. But when we're looking at menopausal patient, it can go up to 75%. Usually it can start with the beginning of menopause, but for the majority, it will start to be symptomatic 4 to 5 years into menopause. 50% of those patients will have impact on their sexual health, and 40% of the postmenopausal women will have urinary tract infections. But we know that those are usually multifactorial, but they can because of GSM. So when we're looking at the full spectrum of symptoms, first of all, we're talking about the vaginal atrophy. So it will present by vaginal dryness. It might be irritation. Some patient will complain of itchiness in the vagina, vaginal discharge, which can be grayish or even greenish discharge. They'll complain of dyspareunia, pain during intercourse. They might even have vaginal bleeding after sexual intercourse. And myself, as a urogynecologist, sometimes I'm seeing patients that are presenting to me with complaint of vaginal prolapse. They feel like something is pulling in the vagina. They feel that they might have a mass or a misplaced tampons. And when I'm examining them, there's nothing at all coming down, but sometimes severe vaginal dryness. So that might be one of the presentation. Lower urinary tract dysfunction with sometimes recurrent urinary tract infection. So when we're facing a patient with recurrent infection in the menopausal period, it's really important to treat the GSM or other symptoms affecting lower urinary tract like urgency, frequency, and pain while urinating. And of course, sexual dysfunction. If the last few experience with intercourse was painful, it will be normal to have decreased desire and sometimes also decreased arousal because of the lack of estrogen in the tissue. And unlike vasomotor symptoms, which in time they will decrease, urogenital atrophy will progressively worsen over time and affect women's quality of life. So GSM is really because of the lack of estrogen in the genital tract. So what we'll see, there's going to be loss of the vaginal rugae or folds in the vagina. The vaginal epithelium will become thinner. The epithelium will be pale, and sometimes we'll even see like the blood vessel underneath and bleeding. So you'll see redness on the vaginal mucosa. On presentation, like I said, the patient can complain of burning, itching, pain with intercourse, or while urinating, a gray or greenish discharge. And you can also see sometimes a urethral prolapse. If we're looking at the vaginal flora, because of the lack of estrogen, we'll see a diminish of there's going to be less glycogen. And with less glycogen, there's going to be less lactobacilli, and then less production of lactic acid. And then we'll lose the good acid pH of the vagina, which will promote the growth of the pathogenic bacteria of the vagina. And if we're doing a wet mount, looking at the cells of the vagina, we'll see more parabasal cell with the big nuclei and less superficial flat cell. Those changes will also happen in the urethra and in the bladder. So in the urethra, we'll see the decrease in the thickness of the mucosa. There's going to be less vascular congestion. The closure pressure of the urethra will be less. There's less collagen and elasticity, and there's going to be more sphincter incompetence. So the patient will have more stress incontinence. So more incontinence when she's coughing, sneezing, making an effort. For the bladder, the thickness of the mucosa will be thinner also. There's going to be a decreased sensory threshold for the detrusor contraction. So we'll see an increased irritative symptoms such as urinary urgency, nocturia, or frequency. So more hyperactive bladder. On examination for the vulva, the labia majora might be decreased in size, but that can also just be due because of aging. And the labia minora will also be decreased in size, and sometimes we see complete loss of the labia minora. The entrance of the vulva might also be decreased, which can sometimes create pain during intercourse because there's less space for penetration. For the vagina, the vaginal canal can shorten, and the epithelium, like I said before, will be thinner with fragile tissue, and the classic appearance is really a pale, dry vaginal mucosa with loss of rugae or folds in the vagina. And also you can see the eversion of the urethral mucosa, which is a urethral prolapse. So this is on physical exam. If you look on the right picture, you see a well estrogenized vulva. So if you look at 6 o'clock, like over here, this is where the labia minora are meeting. And usually this area is soft and you have elastic tissue that will spread with intercourse. But when you look over here, you see that at 12 o'clock and 6 o'clock, there seems to be like fibrosis, and that's because of the lack of estrogen. And those tissue are not so elastic anymore. And this is what will create pain sometime with intercourse. And even at 6 o'clock sometimes, or even 12 o'clock, we will see after intercourse fissure, where the patient will have even bleeding after intercourse because the entrance is so small that it cannot permit or allow a normal penetrations. And that is why sometimes we will propose to those patients a small vulvar surgery, which is called a vestibulectomy, to make the entrance wider. So this is a speculum exam where you can see severe atrophy. You see that the cervix is almost flushed to the apex of the vagina. You see the loss of the folds of the vagina, the white appearance, and even the bleeding in the vagina. So lubricants are often the first option that is proposed or either used by patients because they are usually an option that they can buy over the counter. They are mostly containing hyaluronic acid. They are difficult to differentiate one from the other because the concentration of hyaluronic acid is not always indicated on each medication. So you can compare them by the price. Otherwise, some patient will prefer one to the other. The only difference is for some you have glycerin in it, or vitamin E or liposome, which they have an anti-inflammatory effect. So lubricant will improve vaginal dryness, but of course they will not restore the mucosal integrity. And they have been said to be a good option for patients who have contraindication to estrogen, like breast neoplasia, estrogen-sensitive tumor, and thromboembolic disease. But we will see later on that it is now okay to prescribe estrogen for patients who have estrogen-sensitive tumor. And as for thromboembolic disease, local estrogen in the vagina are such low dose that they can be a safe option to use too. So really, topical estrogen in the vagina is the gold standard. This should be the preferred treatment to promote restoration of the epithelial integrity, restore the vaginal flora, and treat most of the vulvovaginal symptoms. It has been proven to be superior when we compare it to systemic treatment, either oral or transdermal. Randomized control trial comparing local treatment with estrogen versus placebo has shown that patients treated have less dyspareunia and are presenting a reduction in the urinary urgency and dysuria, and also we can see a reduction in the urinary tract infection. So this is a study that is often presented when we're talking about GSM. It was a study done in Canada where patients were treated with local treatment. And then what's interesting in that study is that it was a questionnaire that was sent to the patient, but also to the partners. And it's in French, but I'll translate. Patients were saying that they were experiencing less pain with intercourse after the treatment, that intercourse was more satisfying, that they were more eager to engage in intercourse, and that they felt that their partner had more satisfaction with intercourse once the treatment with local estrogen was done. And this is a study showing that local estrogen is highly effective for preventing urinary tract infection in postmenopausal women. So we are seeing that with placebo, we can have up to almost 6 urinary tract infections per year compared to almost below 1 when we're treated with estrogen locally in the vagina. And it was a cream of estrogen in that study. So risk associated with topical vaginal treatment, it is now safe to use in patients with hormone-sensitive cancers. The North American Menopause Society recommendations indicate that for women with GSM and a history of breast cancer, local treatment therapy may be a reasonable option after failure of a non-hormonal treatment in consultation with the oncologist. So once the treatment for breast cancer is done, we can consider that this treatment is safe. It's such low dose that we can offer it to patients, but we can also offer the possibility of alternative treatments, and we will be talking about it also. So I've listed over here all the treatment that exists, at least in Canada, to treat GSM, and I've written the commercial names because otherwise I would be telling you to use estradiol or prasteron in the vagina only, and I'll be discussing each one of them. So Vagifem is a small tab that's mounted on a kind of a blue stick that you insert inside the vagina. It's estradiol at a dose of 10 micrograms. At first, it's recommended to tell the patient to use it on a daily basis at night before bed for 14 days, and then to decrease the dose to the maintenance dose, which is twice a week. I will tell my patient that it's possible that at some point, if they do develop a systemic level of estrogen, that they may feel like a breast sensitivity. At this point, to just stop using it on a daily basis. Let's say it's happening on the 10th day. So you do 10 days and then you go down to the maintenance dose. If it's not happening, just complete your 14 days and then you go down to twice a week. Imvexi is the newest one, and it's my go-to right now because usually we are telling patients that they should expect like their symptoms to get better in a few months, sometimes in between 3 to 6 months, depending on the severity of the atrophy and when are you starting the treatment compared to the beginning of menopause, or how long has the symptoms been in place. But in the studies regarding the effect of Imvexi, patients were seeing effect as soon as 2 weeks, because you see the capsule is more adherent to the vaginal mucosa, and probably that the absorption is better. So it's the same dose, same medication as Vagifem, but it's really the way it's delivered that is different. So that's why I'm prescribing the Imvexi a bit more, because the results are sooner. Then there's the cream, Premarin cream, which is conjugated estrogen, so not so bioidentical hormone. So I tend not to prescribe it anymore, but it's still available. Estrogyne, it's the a cream also, estrone vaginal cream. The dose is really recommended to be 0.5 grams or a quarter of applicator, and the regimen is the same for 14 nights and then twice a week. Estring is a ring that will deliver estrogen in the vagina. You can leave it in place for 3 months. So it's not something that I use that often, because sometimes patients, they don't know how to use it, putting it in the vagina, removing it. But depending, as a urogynecologist, sometimes I'm using it as a small pessary, I would say. Let's say I have a patient who has a small bladder descent, but then the entrance of the vagina is really too small to use like a normal pessary, and she has GSM. So sometimes I'll use it to support a little bit the cystocele or the bladder descent, and treat the GSM at the same time. And then there's infrarosa, which is a bit different. That's prasterone, DHEA. We know that there are some DHEA will be metabolized in the vagina as estrogen and androgen. And we know that in the vulva, there is some androgen receptors there too. So it's pleasing to know that we're treating at the same time the estrogen and the androgen receptors. And for some patients who are lacking desire, or they're complaining of low libido, sometimes they'll be glad to know that they're treated with a little bit of androgen in the vagina too. Osphena is a SERM, so that's a medication that's taken orally. It's 60 milligrams per day. So it has an agonist effect on the estrogen receptors in the vagina, but it's an antagonism. It has an antagonism effect on the breast and on the endometrium. It cannot be taken at the same time as systemic oral or transdermal estrogen. And I forgot to mention that the intrarosa has to be taken every night before bedtime. So GSM requires local treatment. Systemic treatment may be sufficient, but if not, both systemic and local treatment are needed. So sometimes I'm prescribing both, and I'm receiving a fax from a pharmacist saying, isn't it too much? You're treating systemically and then in the vagina? No, if the patient is needing both, we need to treat at the same time systemic and locally. Let's say I'm seeing a patient for a first consultation, and she's complaining of hot flashes and systemic symptoms, and also of GSM. Depending on the severity, I might decide with her that we're only treating systemically, and we are going to go step by step with the next visit in 3 months. If she has less vaginal dryness, if she's okay with the symptoms that are getting better, we'll stay with the systemic treatment only. And if not, we'll add the local treatment. Or I may decide, if the symptoms are severe enough at the first visit, that I'm starting systemically and also treating locally at the same time. So there are some obstacles to the local hormone therapy, so treating in the vagina. Sometimes hormones are still perceived at risk by some patients. There is also lack of compliance with the treatment. Why is that? Because it's not such a pleasant treatment. It's an intravaginal treatment, so some patients will not like that. Some will complain of the residue of the treatment the next day, like with the cream, with the intrarosa. That's really typical. Some patients will complain that they can be less spontaneous with their sexual intercourse, because if they've just put in something in the vagina, they will not feel as comfortable as if there was nothing and to engage in intercourse after having used the treatment. And some patients are forgetting to use it because it's not something that we're doing on a daily basis. Sometimes it's twice a week, let's say Tuesday, Friday, and they're forgetting one of the dose during the week. So for some patients, either the systemic or the local hormone replacement therapy, they have some pre-existing condition like breast cancer, and even if we're telling them that the local treatment is okay, is safe, they've been told to avoid estrogen for such a long time that it doesn't make sense for them. And some, by their lifestyles or just by preferences, they just choose not to be on hormone replacement therapy. So is there any other options? Well, there are some technologies that you can use in the vagina, and I want to talk a little bit about the laser treatment. There are many types of laser that are used in the vagina. I'm comfortable talking about the Mona Lisa Touch, which is a CO2 laser, and the Diva, which is the Nerbium YAG laser. So I will present some clinical studies. The first one was a microscopic study that was published in Lasers and Medicine Science in 2014. And I really find it interesting. And that was one of the first studies that made me want to buy one laser. It was done on 5 patients who have severe vulvovaginal atrophic symptoms. They took a biopsy of the lateral vaginal wall pre and post treatment. And if I'm showing you the one on top, if you look at the picture on the left, you see this is typical of a biopsy of a menopausal patient. So the number of cells on top, you see maybe 4 or 5 layers of cells, which is the epithelium. You see that the derm is really not so dense when you compare to the picture on the right, which to me looks like a 20 years old. The epithelium is thick with maybe 30 to 40 layers of cells, and the derm is really dense. So this is like looking like a normal, well estrogenized vaginal mucosa. But actually, this is the same patient as the one on the left after 2 of the 3 laser treatment. And all the other ones, this is the same thing that you can see. So it's really telling us that with the laser, we can rejuvenate the vaginal mucosa. We can regrow it to where it was pre-menopause. And this study is a pilot study that was done on 50 patients looking at the symptoms after the first, second, and third laser treatment. And when we're looking at the symptoms on the left, we see that there's really decrease in the amount of burning, itching, dryness, dyspareunia, and laxity of the vagina. And really, I've been working with lasers and patients in the vagina since 2016, and I can tell you that clinically, almost all the symptoms are becoming like insignificant after the third laser treatment. The only symptoms that might persist is pain with intercourse, and you see it's 28% over here. And why is that? There's 3 reasons. In that study, they were treating the vagina only, but with your laser, you need to treat the vulva also, because you can have the atrophy on the vulva, and that's the entrance of the vagina. So it's really important. And then you have to be able to evaluate the architecture of the vulva of your patient. If you have a patient that has fibrosis, like the one that I've shown you at the beginning of the presentation, you might need to add or perform a small surgery to open up the entrance. And then if your patient has been experiencing pain from intercourse for a long time, she might be anticipating pain and she's contracting. So she might need physio to relax the muscle of the perineum too. So those are sometimes what we're planning with patients. Sometimes I'll say, we need to do your laser, we'll do the surgery, and then we'll give you tricks for intercourse. And if not, you might need physio also. And in that study, that wasn't the aim of the studies, but patients were saying, well, my symptoms are getting better, but also my urinary symptoms. So they looked at it, and we were able to find out that there's less pain while urinating, less urgency, less urgent incontinence, and less stress incontinence. So it's not really a treatment for incontinence, but you can expect that your symptoms are also going to get better. So this is the appearance of the vulva in the vagina when you're seeing after immediately after a laser session. So you see that it's creating like some micro trauma, and while healing from it, the vagina only knows how to recreate vagina, and it can regrow, it can grow back to normal, as you saw on the microscopic pictures. So the follow-up is usually annually during a routine exam. Once you've done the 3 sessions of laser, it is estimated that about 30% of the patient will need a maintenance treatment a year after. Otherwise, the patients that are waiting longer will be able to do 18 to 24 months. It really helps to restore the vaginal health by generating new collagen, elastin, increasing the vascularization. It's an in-office procedure that usually requires no anesthesia with no major side effects. And the downtime is usually 48 hours, where we ask patients to not to put anything into the vagina and to abstain from intercourse. So I want to talk now about urinary tract infections. We know that it's the second most most common infections in men and women of all ages. And we women have a higher prevalence 2 compared to 1 due to anatomical differences. Our urethra is shorter, usually about 4 centimeters. And 50% of women will have a urinary tract infection in their lifetime. And it's estimated that 400 million cases per year, and that there is about 400 million cases of urinary tract infection per year. And in the last 2 decades, we've seen that it's even associated with an increased mortality. Of course, it exerts a significant pressure on the healthcare system because it's an economic cost for society. There's reduced productivity and increased healthcare demands. So the pathogenic organisms are well known. We know that the E. coli is the predominant pathogen, representing about 42% of the urinary tract infections, but we can also see Staphylococcus, Klebsiella, Proteus, Enterococcus faecalis, and Proteus. With the use of a lot of antibiotics in the last decades, I would say, we know that there are a lot of resistance. And Dasgupta in his study was able to show that some regions, they have like low resistance rate, but it can go up to high resistance rate up to 88%. And the antibiotics that were once effective are now showing rates of resistance that are ranging up to 28 to 93%. Ume Murat, in some studies that he studied sample of urine, was able to prove that he found that in the urine, 24% of the E. coli was multi-drug resistant. The strains that were found were multi-drug resistant. For Klebsiella was up to 98%, and in about 50% of the sample analyzed, they were able to find that the strain of bacteria that was found was multi-drug resistant too. So that's why we are looking for other options like medicinal plants that have uroprotective activities. Some botanical specimens that have the following properties, some have antioxidant effects, anti-inflammatory agents. Some have the ability to reduce oxidative stress through certain compounds. Some can reduce inflammation, promotes general well-being. And then we have to use less antibiotic, and then we're creating less resistance. So medicinal plants that have been looked at, there's the Camellia sinensis, the green tea, the pomegranates, the chamomile, and also the cranberries, the cranberries. And those are the ones that we are going to talk about. But how are they working? They are working because of the molecule that is the proanthocyanidins. We will call them PACs, which will make it easier. They are of type A chemical structure, unlike type B, which are found in some other fruits. They are mostly working by preventing bacterial adhesion to the bladder wall, and I will show you how they are doing that. Other compounds present in the cranberry will be flavonoids. they will give the red pigment to the cranberries. Flavonols are powerful antioxidants. They can neutralize free radicals and reduce oxidative stress. And phenolic acid are anti-inflammatory and they also have antimicrobial properties. So really, how do PACs work? Well, PACs are molecules that are similar in shape to the receptor of the urinary tract wall. So you see over here the receptor and PAC molecule. They adhere to the bacterial P. fimbriae to help stop the bacterial adhesion. And then the bacteria will be flushed while the patient is urinating in the outflow of urine. So PACs are effective against a variety of bacteria, including E. coli, Klebsiella, and Enterococcus faecalis. Flavonoids and phenolic acid that are also contained in cranberries have an antimicrobial effect. These compounds interfere with communication and inhibit essential enzymatic activities within the bacteria. And some research shows that the antimicrobial effects of these extracts could have a potential role against multi-drug resistant E. coli strains. So those are different ways that the cranberries are contributing to the management of the prevention of urinary tract infection by the anti-adhesions, antimicrobial, and anti-accident effect, also the anti-inflammatory effect. So it helps reduce the symptoms, and it also helps prevent the recurrence rate of urinary tract infection. So the pharmacokinetics of the PACs, they are usually absorbed orally, but because of the complexity and the large size of the molecules, they have limited oral bioavailability. They are metabolized by the liver and the intestines, and then they'll be excreted through urine, which will enable effective activity. So I'm going to present you 3 studies where they looked at the effectiveness of PACs to be able to prevent urinary tract infection. So the first study was done by Thomas and colleague, and it was really to evaluate the efficacy of oral cranberry supplement on subject with long-term catheter, with patient who had long-term catheter and urinary tract infection. So in this study, 34 patients were registered in the trial and were enrolled to take a once daily oral cranberry supplement with 36 milligrams of PACs for a duration of 6 months. And they were able to show that the resistance to antibiotic was reduced by 28% and that the colony counts were reduced by 58% without any adverse effect while taking the supplements. So in conclusion, the cranberry supplement reduced the number of symptomatic urinary tract infection in patients having catheter, antibiotic resistance, and measured causative, and there was no measured causative secondary effect. Diane and colleague then evaluated the ability of the PAC extract to prevent urinary tract infection, but this time in the general population and in the hospitalized patient. It's a meta-analysis that compared 10 randomized controlled trials on the effectiveness of the cranberry extract. They were able to show a urinary tract reduction in about 18%, and it was significant with the 36 milligram of PACs. And there was no significant reduction when the dose of PAC was lower than 36 milligram. They were also able to show a significant reduction in the urinary tract infection risk only when the treatment duration was in between 12 to 24 weeks and when women were included in the treatment group. So it's the first meta-analysis that demonstrated a minimum effective dose of 36 milligrams. The last study was done by Howell and colleague, and it was to evaluate the anti-adhesion effect following 36 or 72 milligrams of PACs. So the ex vivo urinary bacterial anti-adhesion activity was assessed on urine samples collected from 2 volunteers. They were able to show that the anti-adhesion effect was lasting at least for 24 hours with 36 milligrams, and it was more profound and prolonged with 72 milligrams of PACT. So in conclusion, it was possible to say that it was effective and sufficient to use 36 milligrams for 24 hours, and that the effect was stronger and longer with 72 milligrams. So this is a natural option using 36 milligram of PACs from cranberries, and it's been proven to help prevent urinary tract infections by stopping a variety of bacteria from sticking to the bladder wall. And it's a good prevention, and it's been supported by a variety of professional associations in Canada, like the Canadian Urologist Association, the Society of Obstetricians and Gynecologists, and the family physicians also. So what's interesting in the Utiva, when we compare it to the other, we see that the size of the capsule is really smaller. You see that the color, it's pure dark red, like cranberry, so like the cranberry appearance. There's probably less filler in this one, and it's really locally sourced and produced. But also, what you have to be careful and really looked at, sometimes when we're looking to buy something, sometime online, because those products can be found online, if we compare the amount of the cranberry that can be found, sometimes you'll see that there are some capsules that are promoting 500 milligrams of high dose of cranberry capsules, but typically they have less than 1% PACs in them. So this is less than 5 milligrams per capsule. But when you compare it to the Utiva, which has only 240 milligrams of cranberry, but with 50% concentration of PAC, you then have your 36 milligrams. So it's those two are not comparable. And if you're seeing that study that was done at Rutgers University, they were comparing different supplements. So you see that on the left, high concentration of 500 milligrams of cranberry products showed no measurable activity against E. coli, and only products containing 36 milligrams of PACs were most effective in anti-adhesion activity against E. coli, and that the Utiva was the most effective one. And this is when it becomes really interesting, because that can be a really good option to prevent recurrent urinary tract infection. And usually the dose with the recommended dose could be 1 capsule daily. When it's you want to prevent sex-associated urinary tract infection, you can either prescribe 2 capsules before or after intercourse. Personally, I'm never prescribing before intercourse, because it's not always possible to be able to predict when you are going to have intercourse. And I'm always telling my patient, if you're prone to have urinary tract infection, always go to the bathroom, flush the bacteria, urinate after intercourse, and take your 2 capsules of Utiva right after intercourse. If you are more sexually active, you could take the medication on a daily basis, and then when you do have an intercourse, you add 1 more per day, so you're taking 2 on those days. And when it's also what's also interesting is that if you're treating a patient, you're planning to start the local treatment with estrogen treatment, don't forget that it might take a couple months for the local estrogen to take effect, and in those gap months, you may have recurrence of your urinary tract infection. So for the first 4 to 6 months, you can start your patient on local treatment and add 1 tab of Utiva per day to cover that gap period where the estrogen is going to start to take effect. One last word, I want to talk about the D-mannose, which is a simple sugar similar to glucose that is also known to prevent urinary tract infections, especially those caused by E. coli. It's working in a similar way as the PAC are working. D-mannose is similar in shape to the mannosilated uroplakin receptors on the urinary tract wall. And these receptors fit perfectly with E. coli's type 1 fimbriae. So when D. mannose is present in sufficient amounts, it can bind to all the E. coli fimbriae and inhibits bacterial adhesion to the urothelium. Natural flushing occurs as the bacteria is eliminated via urine out of the bladder. So it works in a similar way as the packs are working. Each capsule of D. mannose capsules contains 500 milligrams of D. mannose, but the dose should be 2,000 milligrams per day. So you would be using 2 tabs 2 times a day. So in summary, why is urinary tract infection increased at menopause? Well, this is because there is decrease in the level of estrogen. You'll have thinning and atrophy of the vaginal wall and the urethra the mucosa of the urethra, which you'll then have decrease in the vaginal glycogen, which will bring reduction in the lactobacilli, and therefore you'll lose the protection of the normal acidic pH of the vagina. You will then have colonization by the bacteria of the intestine, the E. coli, and you'll have a complete loss of your normal microbiome in the vagina, and you'll be more prone to have urinary tract infections. So if we're looking at those 3 treatments that we have, the local treatment, the PACs, and the D. mannose, they can really work together in different ways. The restoration of the vaginal flora and normal vaginal pH can be stimulated by the local treatment with estrogen, but not with PACs and D. mannose. The estrogen will stimulate the presence of lactobacilli and will recreate the vaginal acidification. They can all prevent the colonization by E. coli indirectly via restoration of the vaginal microbiome by the local estrogen. And the other 2, we know that it's because they're blocking the adhesions of the bacteria on the wall of the mucosa of the bladder. So those prevention are present with the PACs and D. mannose, but they are not done with the local estrogen. And it's been proven in studies, there's numerous studies and strong evidence that the local estrogen treatment is good to prevent urinary tract infection recurrence, and good preventive efficacy have also been proven with PACs and D. mannose. And this is to say that we have used a lot of treatments in menopause for hot flashes without good evidence. But we have good evidence that PACs and D. mannose are working for prevention of recurrent urinary tract infection. So this is something that we have to keep in mind, and we can propose to our patient to also reduce the amount of resistance to antibiotics. So this is what I had to say on the subject tonight. So I'm going to stop sharing my screen and maybe ask Olivia if there's any questions.
Thank you so much for your excellent presentation, Dr. Leroux. Again, thank you. Yes, we received quite a few questions, so we're going to do our best to cover as many of them as possible within the next 10 to 15 minutes. But before starting with the Q&A session, we've also received some questions regarding the recording. So yes, I'm happy to confirm to everybody that the webinar is being recorded and that you'll receive the link to the replay or to the recording in your mailbox by next week. And we will be also sharing the PDF, which Dr. Leroux kindly agreed to share with all of you. So thank you all. And now I think we're ready to start with the questions. So Dr. Leroux, the first question we received is vaginoplasty surgery covered by a OHIP?
Well, if you're talking about the vestibulectomy, yes, it's covered by the OHIP. It can be done as an office procedure. Personally, I'm in a private clinic, so we're charging the patient. But yes, it's covered by the RAMQ. It's covered by the OHIP. It can be easily done. Yes, it's a small procedure.
Great. Thank you, Dr. Leroux. Then we have, is it possible to combine therapy for GSM, in example, Invexi and Intrarosa?
Usually no, because they're doing the same thing. So you're using two treatments at the same time. So I would use either one or the other.
Perfect. Thank you. Then we have, is it okay? If it is okay, is it safe to prescribe oral and local estrogen?
At oral and local estrogen at the same time, yes, that's what I was saying. Really, it's
Mhm.
systemic treatment. So if the patient is on systemic treatment but is still symptomatic locally, you need to add the treatment in the vagina. So that's not adding too much. I'm always saying to my patient, let's say this is your systemic treatment. Like the local treatment is like 2 drops of water in this. This is almost nothing. So you shouldn't be scared to add the local treatment.
Thank you, Dr. Leroux. Then we have, can GSM symptoms begin in the early 40s?
Sometimes, and you can even see it, and it will not be called GSM because it's not with menopause. But let's say sometimes you have to think about it on a patient who's been on birth control pill for many years. Sometimes they'll complain of vaginal dryness, and this is because of the effect of the progesterone that you've been using for so long, and at some point it's creating like vaginal dryness. So you may see it on a patient who's been on birth control pill for a long time. And depending as early as 40, it's really depending on how the patient is presenting. Sometimes she might be in perimenopause because we know that menopause is around 52 years old, but it can start like 45 to 55 and it can start 10 years before menopause. So if you are going to be menopause at 45, you can have symptoms that are even starting like in your late 30s, beginning of your 40.
Thank you, Dr. Leroux. Then we have, what is your recommendation regarding cream versus suppository estrogen treatment? Reason of choosing one over the other?
That's a very good question. Like I was saying, right now I'm prescribing if the patient has if she has a insurance, I'll prescribe Invixi because I know that the response is faster, like within 2 weeks. Otherwise, it's really depending on the patient personal preferences. So sometimes I'll explain that there's stab in the vagina, that there's cream, and I'll start with that and I'll talk to the patient 4 months after. If it's not working or if it hasn't started to get better, I'll switch. If I'm on the cream, I'll try, let's say, Vagifem, and I'll do the contrary. And sometimes patient will respond better to one to the other. So is it because I'm switching and the response is better, or is it only because I'm continuing to give estrogen in the vagina in the long term? I don't have the answer to that, but sometimes I'm just switching it. Also, sometimes I'll use a cream if I'm seeing that the vulva is really atrophic because I want to split the dose. I'll put a little bit in the vagina and I'll tell them to put a little bit of cream on the outside when they're really complaining that the outside is dry. So that would be like a reason to start with the cream. But any treatment is good at this point.
Perfect. Thank you, Dr. Leroux. Has radio frequency treatments been shown any benefit? Have they
Yes,
shown
it's
any
a
benefit?
treatment that we also have at the clinic. Radio frequency is working a bit differently compared to the laser. Laser is creating a trauma in the mucosa, and then the vagina has to repair and then regrow to its normal shape. The radio frequency is working by putting like heat to the tissue. It will stimulate the elastin and the collagen, and the results are kind of similar. So why will I offer one to the other? Sometimes it's the probe that's used for the treatment. The probe which we use for the radio frequency at our clinic is smaller than the one that we have for lasers. So some patients who have like severe vaginal or the entrance is so small, I cannot sometimes use one of my laser. So I will use the radio frequency. That's the only difference, but the endpoint results are about the same.
Thank you, Dr. Leroux. What is your recommend? Oh, sorry, no, this one I went over. Sorry, this is the one I wanted to share. Do you still prescribe compounded progesterone micronized USP in a Versopro cream base?
You know what you said? You
Versapro cream base?
prescribe it on the skin, you mean? So if it's
I
compound on the
believe
skin,
so, yes, because it's a
systemic,
cream
we're never
compounded.
doing that. We're never using compounds because we have good products in Canada that are approved by Santé Canada. And we also know that progesterone is not absorbed through the skin. So you're not protecting your patient if you're giving it compound through the skin. We are using micronized oral progesterone.
Correct. Thank you, Dr. Leroux. Is laser treatment approved by Health Canada?
Is there
Laser treatment
laser
approved.
treatment approved by Santé Canada? Well, all the
Oui.
technologies, they have to be approved by Santé Canada. So our devices are approved by Santé Canada, of course.
Then we have, if the patient is on anastrozole, is it still safe to have local estrogen?
It is now said to be safe, but of course, it's always weighing the risk and benefits and discussing it with the patient. But at the clinic, since we have the laser, I would say that most of our patients would choose like having a technologies than to have to put estrogen in the vagina while they're treated for the breast cancer.
Correct. Uh, have there been any studies with vaginal estrogen in long-term care residents with recurrent UTIs?
Yes, yes, and it's been shown to prevent urinary tract infection.
Perfect. How do you choose estradiol 17B 10 milligrams versus 4 to 8 milligrams, meaning Vagifem versus Invexi?
Yes, yes, yes. I don't know why they produce the 4 milligrams. It's nothing. So never prescribing it. The only time that I used it, it was because I had a patient who was complaining of breast mastalgia, headaches with the 10 milligrams, but I wasn't even sure if it was really real, but I lowered my dose to the 4 milligrams and she's tolerating it really better. But to me, for the efficacy, you really need a bit more. So you need 10. And I just want to remind you that when it first came out, Vagifem was 25 microgram, and we don't even know why the company decreased to 10. So it used to be 25 twice a week, and it was working really well.
Thank you, Dr. Leroux. We have the same question twice. So how does the Manos compare to cranberry by itself or Pax
I
Manos?
don't know, Olivia. I think we had the same question last time. I don't think that it's been
Yes.
studied, eh?
Mm-hmm.
Both compared to the other. No,
No, no, not really. No
no.
clinical studies head to head. Mm-hmm. So they're wondering, when would you recommend Pax versus the Manos?
I would say that you can even give both at the same time if you have difficulty preventing urinary tract infection because they're not working on the same receptors. So you can use both at the same time if you want to prevent. But most of the time, I will start with Pax first.
Thank you, Dr. Leroux. Is Manos safe for diabetic patients?
Yes, yes.
Any research on vaginal probiotics to improve vaginal health?
No, not really, but I'm just telling you once again, you're not restoring the vaginal flora by taking probiotics because the lactobacilli are not there anymore because there is no glycogen. It's really because you're lacking estrogen. So this is what you need to be treating. So probiotics will be used when you have problem with the balance of your vaginal flora, but mostly pre-menopause. It's not something that I'm using on a menopausal patient.
Thank you, Dr. Leroux. We've gone through quite a few questions, so if you agree, there will be just one last question.
Of course.
And I thank you, everybody who entered their questions, and also thank you for your understanding in those cases where we weren't able to get to your questions. So we have, with the entrance to the vagina being atrophied prior to laser or radio frequency, would you recommend the vaginal estrogen with dilators?
I'm not really doing dilators for the vulvar atrophy because it's not really working. That's not something that we will dilate easily. Like the picture that I've shown you with the fibrosis at 12 and 6 o'clock, it's really hard to dilate. So I will open up the entrance surgically, usually, because otherwise it would take a lot of work from the patient, and most of the time it's not successful with dilators.
Thank you so much, Dr.
You're
Leroux.
welcome.
I
So
believe
hopefully that was
it was
helpful for you.
thank you. I believe we have very, very good comments, and it seems like the attendees are quite happy. So thank you. Um, we are still getting some questions. I apologize with everybody, and thank you for your understanding. It's already been an hour since Dr. Leroux has been with us, so thank you. You will all receive the recording in your mailbox by next week. Thank you so much, and we would like to invite you all to stay with us because we're going
Thank
to do
you.
the raffle, and we wish you a very good evening, Dr. Leroux.
Thank you
Thank
so
you
much.
again. Bye bye.